My name is Santosh. I'm one of the Interventional Radiology SD5s in the Wessex School of Radiology, which Southampton is based, currently based in Bournemouth. Today I've been given the task of speaking to you about interventional oncology with a focus on ablative techniques. So interventional oncology is considered a pillar in cancer care alongside medical, surgical and radiation oncology. So our patients typically referred by the GP with symptoms, get a scan, and if there's an abnormality, they first get referred into the hospital to see a medical oncologist who will then discuss this case in the MDT with relevant bits of information, and the various other specialties get involved as required. If the case is suitable for an interventional procedure, they will then be referred on to the interventional radiologist, and they get seen in a radiology clinic, which is often joint clinic with an oncologist or a hepatologist, and they will go through the interventional oncological procedure proposed with the patient, explain what it entails, get consent in clinic prior to the date of the procedure, then give them a date of the procedure, and on the date of the procedure, confirm the consent with them prior to the procedure. Do not, as following the consent guidelines, do not consent on the day of the procedure. You're only confirming consent on the day. So interventional oncological practice comprises various procedures and is broadly categorized into diagnostic, where we take tissue samples, such as biopsy or aspirates, with image guidance, vascular access techniques, simple Hickman lines or dialysis catheters or portacats, therapeutic procedures, which include ablative techniques, which we'll discuss in more detail today, and catheter-directed treatments, such as transarterial chemoembolization, where we're delivering chemotherapy to an organ, such as the liver, or transarterial radioembolization, otherwise called systemic internal radiation therapy, where we're delivering beads carrying radioactive material into the liver. Palliative procedures such as drainages, which may be ascites, pleural effusion, biliary drainages, or nephrostomies. Moving on to ablative treatments, which we'll talk about in much more detail today. Again, broadly categorized into thermal and non-thermal techniques. And off the thermal, we'll be discussing radiofrequency ablation, microwave ablation, and cryoablation, of which radiofrequency and microwave use heat, and cryoablation uses cold. Non-thermal ablation, we'll be discussing irreversible electroporation, which I have to admit I don't have much experience with at all, outside of a demo setting in conferences. Radiofrequency ablation. In radiofrequency ablation, we use a closed electrical circuit. So there'll be grounding pads on the patient's skin, usually on the thighs, and that acts as the anode. And there'll be an inserted electrode into the body, into the target lesion, and that is the cathode. And we'll pass alternating current through the electrode that causes resistive tissue heating. The heat is conducted by indirect heating of the adjacent tissue, forming an ablation zone by coagulous necrosis. Now, tissue charring or boiling will raise the impedance or resistance, and it is susceptible to the heat sink effect. Now, heat sink effect is a phenomenon where that reduces the efficacy of the ablation when the target lesion is in close proximity, i.e. within a centimetre of a large blood vessel that is defined as being less than or equal to, greater than or equal to 3. Okay, so if it is within a centimetre of a 3 millimetre vessel or more, you are susceptible to heat sink effect, which means that the blood flowing within that blood vessel close to the target lesion will cause cooling and reduce the efficacy of the ablation. Clinical applications of RFA, you can use it for hepatocellular carcinoma or liver metastases. When you're using it for either, give the option of an interventional oncological procedure when there's up to 3 lesions that are less than 3 centimetres in size, and there's no extrahepatic disease. When you have extrahepatic disease, these curative treatments fall out of the algorithm. For RCCs, you want the tumour to be less than 4 centimetres, which is typically a T1A tumour. For lung, it needs to be less than 3 centimetres and over a centimetre away from key structures such as the trachea, main bronchi, esophagus, and central vessels. Patient selection is through MDT, where the imaging is discussed with all the relevant oncologists and clinical team present. Electrode placement will be under CT or ultrasound guidance, and the treatment is per departmental or kit-related guidance. Different departments use different kit, and the guidance varies with the kit. Follow-up imaging is typically in a month to assess response, and RFAs are typically quick day case procedures, usually with sedation, radiological-led sedation, rather than anesthetic-led sedation. This is an image of a Boston Scientific Levine system. And so you've got don't know if you can see my cursor on the screen. So this is the box where you connect the grounding pads on here, and you set the energy on here. That's the wattage, and the time on here. So you typically start at about 50 watts, increasing 10 watts every 10 seconds up to about 90 watts. And then you'll wait for about 5 minutes from the start of treatment. And what you're looking for is a rise in impedance, where you have this number 50 go up to about 900 odd, and this bar will go right up to the top. So when you get impedance, we call it roll-off. When you've attained roll-off, you stop, wait for 5 minutes, and then start again. And again, you're looking for roll-off again. So there's phase 1 treatment and then a phase 2 treatment, the endpoint being attainment of roll-off. And these are the needles. So this is an undeployed needle. So you insert this through a coaxial introducer into the patient under CT and or ultrasound guidance. And then once you are happy that you're in the lesion, you press a button at the top, and that will deploy the tines. These are called tines. And with these tines, you want them through the lesion, extending beyond the lesion. So the tines, the proximal bit of the tines should be through the lesion, and the distal bits of the tines should be beyond the lesion. That is how you get an ablated margin. So you're burning the tumor and a little bit of normal tissue around the tumor, typically about 5 millimeters. It's the aim, 5 millimeters of normal tissue around the tumor. So just as you talk about resection margins in surgery, you have ablated margins, and the aim is about 5 millimeters of normal tissue around the tumor to reduce the risk of recurrence or residual disease. Moving on to the next modality, microwave ablation. So microwave, you use electromagnetic energy, and you create an ellipsoidal zone of tissue heating by dielectric hysteresis. That is, water molecules align themselves with an oscillating electrical field, producing kinetic energy that is converted to heat. Microwave produces more predictable ablation zones, produce higher temperatures. It is faster than RFA and produce larger ablation zones. It is less reliant on conduction of heat and hence less susceptible to the heat sink effect. It can be applied to treat larger liver lesions, and you can use multiple probes simultaneously, whereas in RFA, you can only use one probe at a time. Clinical applications are similar to RFA, though, only the difference being you can use it for larger lesions. So for HCC and METs, again, up to 3 lesions normally, but size, there's a difference. You can treat up to 8 centimeters. For RCCs, very similar, less than 4 centimeters, or T1A tumors. For lung, variable practices. So if it's a primary lung lesion, you need it to be less than 3 centimeters. If they're metastases, less than 3.5 centimeters and up to 5 lesions. Although again, there are variations in different practice settings. We almost have treated lung metastases in patients who've had up to 9 metastases. Patient selection is through MDT, and electrode placement is again under CT or ultrasound guidance, and treatment as circulator guidance. Follow-up imaging, again, typically in a month, and it's typically a day case. In Southampton, all microwave livers are done under general anaesthetic, but in Bournemouth, some of them are done under sedation, radiological sedation. Here, there are a couple of microwave systems. On the left, you have the New Wave system, which we use in Southampton, which is quite bulky, and you've got planning software embedded into the system. It is connected to your imaging network, and you can load the planning CT onto this, register the target lesion, find the target lesion, register the probe, and it will give you a predicted ablation volume. On the right here, you have a much simpler system, which is the Covidian imprint system. So this is the Covidian imprint probe, and that's the New Wave probe. On the Covidian imprint system, you only have the ability to set the energy time. That's about it. All the planning is not involving the system itself. Differences between RFA and microwave, we've already discussed most of them. So RFA uses electric current, microwave electromagnetic energy. RFA uses grounding pads and hence has the added risk of skin burns. No grounding pads in microwave. RFA, there's tissue charring and boiling, rise in impedance that will reduce the electrical and thermal conductivity. We don't have that in microwave. There's rapid and homogeneous heating and ionic polarization. You attain lower intratumoral temperatures in RFA, higher intratumoral pressures in microwave. Peri-procedural pain tends to be higher with RFA than microwave. Less predictable ablation zone with RFA, more predictable in microwave. RFA more susceptible to the heat sink effect, and microwave less susceptible to the heat sink. RFA typically single lesion at a time, whereas microwave multiple probes can be used simultaneously. More procedural time with RFA, less procedural time with microwave, less ablation volume with RFA, more with microwave. And the most important for me, I think, is surgical clips and pacemakers are contraindications for RFA, because they're not contraindication for microwave. So it can be used more widely. Moving on to cryoablation. In cryo, we use a combination of rapid cooling produced by decompression of argon gas within the probe that you place in the patient, and it's called Joule-Thomson effect. That's a decompression of gas causing a drop in temperature, and it's followed by thawing. And thawing can be either passive or active. And passive is without any use of gas, and active is by passage of helium gas through the same electrode. It leads to coagulative necrosis and cell death by formation of intracellular ice crystals, and these ice crystals will interrupt the cellular membrane and cellular metabolism and cause ischemia by causing vascular thrombosis. One of the major advantages with cryo is that you can monitor the treatment intra-procedure by imaging. You can see the ice ball forming, and if it's not forming in the shape or region that you wanted it to, you can readjust needles mid-procedure, although most people are loath to do that. Being able to see the ice balls will increase the chance of you having a complete ablation and reducing the risk of injury to critical structures. It is less painful compared to heat-based therapies when involving structures such as subcutaneous tissues, pleura and diaphragm, and it has a wide range of clinical applications, including lung, breast, kidney, bone, and soft tissue tumours. When it comes to the lung and kidney, most of these procedures are under GA, and they tend to have an overnight stay and then discharge the following day. Patient selection, as with anything, through MDT. Probes are placed under CT, MR, or ultrasound guidance, or whatever you can see the lesion in properly, whatever you're going to use for intraprocedural monitoring and use for probe placement. And it's very common to use multiple probes. Typical cycle has a 10-minute freeze, and you do a 10-minute thaw, and then a 10-minute freeze again, and then usually typically a 2-minute thaw, and then you can try and have a pull on the needle, a gentle pull on the needle, and see if it comes out. Then withdraw the needles and put some dressings on. Most renal cases, as I said, are on the GA, discharge the following day, follow-up imaging typically in 1 month. This is an image of a cryoablation apparatus that we use in Bournemouth, marketed by Boston Scientific. It's called the ICE-FX system. So this is on this apparatus here. You can set the mode to freezing or thawing. You can set the time for it. And on this, you can connect up to 8 needles, so 2 on each port. And they've got a wide variety of probes, as demonstrated here. And each of these probes, they have literature showing you what shape and size that you can expect of the ice ball to form. Each probe will produce a different shape and size of the ice ball. Moving on to the non-thermal technique that we'll be discussing, which is irreversible electroporation, which is what I don't have any experience with. Here there's use of non-thermal energy-based ablation that will create pores in the cellular membranes by delivering short bursts of high voltage electrical pulses, typically direct current, as opposed to alternative current in RFA. The extracellular tissue architecture is preserved, and so we can use this near aqueous structures such as the biliary tree or vascular structures. It is not susceptible to heat sink, so it avoids incomplete ablation in major blood vessels, which is one of its perks. And because you're preserving blood flow into the ablation zone, the inflammatory cells that flood to the area remain perfused and instigates a systemic anti-tumor immune response, resulting in an abscopal effect. And an abscopal effect is it is a regression of non-target lesions. For example, if you've got liver lesion and a lung met, and you're targeting the liver lesion with IRE on follow-up imaging, you may see that the liver lesion has responded, i.e. you have a zone covering the lesion, and the lung lesion may have either reduced in size or disappeared altogether. So that's what abscopal effect is, which is pretty cool. It is time-consuming and technically challenging because it requires parallel placement of multiple electrodes, often under CT guidance. It can cause muscle contractions and cause cardiac arrhythmias, and therefore usually requires GA for muscle paralysis and cardiac synchronization. And we cannot tract ablate. So tract ablation is when we, at the end of treatment, if you're removing an RFA probe or a microwave probe, you can set it to a low energy and short time on the apparatus as you're withdrawing it, so that you are burning the tract through which you're withdrawing the needle through. By doing that, you're reducing the risk of sealing the tract with tumour. Can't do that in IRE. Clinical applications of IRE, you can use it in the liver for peribiliary lesions, so lesions close to the biliary tree, in prostate, and in locally advanced pancreatic cancer. This is an image of a NanoKnife system, again, quite bulky machines. That's the apparatus and the probe and cardiac synchronization device. Move on to case. So before we start with the case, got a couple of cases, we'll go through them. So case one is a 63-year-old lady with a previous history of right nephrectomy for RCC, with renal cell cancer, and now presenting with multiple lesions in her single left kidney with suspicious RCC lesion. So she went through the MDT, she was out of area, and she was referred in for treatment because we offer it locally. And on pre-treatment imaging, we could identify up to 4 lesions in her single left kidney. And on the day of procedure, on the pre-treatment imaging on the day, we identified 6 lesions. So as highlighted here at the upper pole, this one here. As we go down, 2 more lesions, and another endophytic lesion here, and a few more further down. So 6 lesions, and we ended up using 9 needles on this lady. So you can count 1, 2, 3, 4, 5, 6, 7, 8, and 9. 9 cryoablation needles plus 3 hydrodissection needles. Now, hydrodissection is where we place in cannulas on different sides of the kidney and inject fluid mixed with contrast that is visible on the CT to push away key structures such as bowel and or other solid organs that's close to the kidney to avoid any risk of injury to those with the cold energy that we're delivering into the tumours. 9 cryo needles, 3 hydrosection needles, 12 needles in small space around the kidney. It's quite crowded, and plus a biopsy as well. So this is the treatment, mid-treatment imaging. So we typically do, as I said, 10-minute freeze, 10-minute thaw, 10-minute freeze. And at 4 minutes from the first freeze cycle, we do 1 CT. Then at 8 minutes in the first freeze cycle, another CT to see the ice balls forming. And this is giving us the opportunity to readjust our needles if we need to. And then in the second cycle, typically another CT at 8 minutes of the second cycle, and that's it. So here, this is the 4-minute first cycle CT intra-procedure. So you can see the needle 1, 2, 1, 2, 1, 1, 1, 1, 2. And you can see the ice ball nicely forming as areas of hypoattenuation, very well circumscribed round ice balls with the needle right bang in the center of it. And what you're seeing is high density around the kidney is the hydrodissection fluid that is pushing away bowel and liver away from the kidney. This is the CT image from 1 month post-treatment, showing the ablation zones in areas what were the enhancing tumours. Now there's no enhancement in these areas, complete treatment, complete response. It's pretty good. Good way to treat cancer. Case 2. We have a 6-year-old male, incidental detection of a large 13 centimetre hepatocellular carcinoma on lung health check CT. So HCCs are those, if we've got conclusive imaging, if we are quite confident in imaging, they're often not biopsied and they proceed straight to treatment, either surgical or interventional or palliative, because they're quite confident imaging characteristics that are often present, which is arterial phase enhancement, weakness or shock on CT. So this is, he had smoker, lung health check CT, non-contrast, abnormality in the liver, MDT, proceeded to proper CT, and that showed HCC. And he underwent SIRT, so systemic internal radiation therapy, or TARE, transarterial radioembolization, for large right lobe disease. On follow-up imaging after SIRT, there was involution of right lobe disease, but with new foci in the left lobe, went through MDT again, and the recommendation was for ablation, not the new foci. So on this CT image, so we've got, that's the aorta there, vertebral body, and the aorta is very bright because contrast is mostly in the aorta, so it's an arterial phase CT. And this is in blue, we've got highlighted the right lobe bulky lesion, and that was treated with CERT. Adjacent to that is a rounded structure with less contrast than the aorta, and that's the hepatic cava, inferior vena cava. And adjacent to this right lobe, this is actually the left lobe. So you've got right lobe atrophy, cirrhotic patient, and left lobe hypertrophy. So this lesion is in the left lobe, a tiny lesion of arterial phase enhancement, in keeping with, and there was in this phase washout, so this was in keeping with HCC as well. A further lesion further down, still in the left lobe, and these were selected for ablation. In the liver in Southampton, we do microwave and using the new wave system. So this was intra-procedure needle placement, new wave system. This is the post-treatment image on the same day showing low attenuation within the liver with peripheral enhancement. That's the ablation zone. And this is the needle through the second lesion that we were going to treat, and that's the low attenuation of the treated lesion, ablation zone. That's in blue is the previously treated lesion. That's a CERT radiation treated lesion in the right lobe. However, this patient did not have as favourable an outcome as the previous patient. It's just because the disease was aggressive. On follow-up imaging, a couple of months down the line, we have residual disease or recurrent disease at the same sites with continued involution of the right lobe disease. But although it continued to involute, which is what you expect after CERT or TER, there remained continued enhancement. And so they re-biopsied that, and there was still viable disease in that as well. So he did not do very well. That brings us to the end of today's talk and a couple of my references. Thank you. That's the end of my presentation.